Hello and welcome to the second annual Breast Decisions event. I am Kimberly Carter, an Orlando Health team member and your host and moderator for today's event. I want to thank you for joining us in our new virtual format this year. Our top priority is the health and safety of our community, which is why we're glad to bring today's rich content to the comfort of your home. For those newly acquainted with Orlando Health, I want to share a little bit more about us. Orlando Health is a not-for-profit healthcare organization dedicated to improving the health and quality of life of the individuals and communities we serve. Founded in Orlando, Florida, more than 100 years ago, Orlando Health now consists of 15 wholly owned hospitals and emergency departments throughout Central and Southwest Florida, along with rehabilitation services, cancer institutes, heart institutes, physician offices for adults and pediatrics, and much, much more. Caring for our community is at the heart of what we do. And last year, we are proud to have provided more than $760 million in charity care, community benefit programs, and community building activities across the region. So today, we look forward to providing you with information from all aspects of the oncology team for both current patients as well as survivors and their support team. Now, before we begin, I would like to review a couple of housekeeping items. On your screen, you will see an outline of available icons. If you wish to submit a question, you may do so at any time by typing your question or comment in the QA feature located at the bottom of your screen. At the end of the panel discussion, you will also have an opportunity to raise your hand and ask questions. All questions will be monitored throughout today's presentation and addressed at the end of our discussion. Additionally, please take a moment to review the privacy policy that's also located on your screen. Now, following today's event, we will provide you with a list of resources offered by Orlando Health and some of our external vendor and partners, which are beneficial throughout any part of your treatment journey. Look for an email that will be coming soon labeled Orlando Health Breast Decisions 2020. Also, as a thank you for attending today's event, all attendees will receive a complimentary pink ribbon face mask, looks like this. Details on how to pick up your face mask are on the screen and will be included in the follow-up email that you're going to receive. At the very end of today's event, we will also announce the names of 2 lucky winners from our random drawing to receive a special Orlando Health gift bag. Winners must be present in the webinar during the drawing to win. Okay, so let's get started. I want to begin by introducing today's panel of experts, and I'm going to start with those on my right. So I first want to start with Dr. Ram. Dr. Ram is a board-certified surgeon who has limited her surgical practice to breast surgery for the past 22 years. She works with patients to create a personalized treatment plan for each patient's specific type of stage of cancer. She is a member of the American Society of Breast Surgeons, and we're also excited to announce that Dr. Ram will be joining the Orlando Health team in November of this year. Welcome, Dr. Ram. Next to Dr. Ram is Dr. Constantino. Dr. Constantino is a medical oncologist and hematologist at our UF Health Cancer Center in Lake Mary. She is a board certified in hematology, medical oncology, and internal medicine. She also has been a member of the American Society of Clinical Oncology since 2008. Welcome, Dr. Constantino. We now have Dr. Swanik. Dr. Swanik is a radiation oncologist at our UF Health Cancer Center. She is board certified in radiation oncology and is also trained in proton therapy. She is a member of our American Society of Radiation Oncology and American Society for Clinical Oncology. Welcome, Dr. Swanik. We also have, sitting right next to me, is Dr. Betas. Dr. Betas is a board-certified plastic and reconstructive surgeon with Orlando Health Aesthetic and Reconstructive Surgery Institute. He specializes in contouring after weight loss, or body contouring, after weight loss and breast reconstructive surgery. Dr. Bates is a member of the American College of Surgeons, American Society of Plastic Surgeons, and American Society for Aesthetic Plastic Surgery. He has published extensively in peer-reviewed journals, written several chapters for medical texts, and presented his work at many national meetings. So welcome, Dr. Bates.
Thank you.
To my left is Dr. Robinson. Dr. Robinson is the Program Director of the Cancer Support Community and the Integrative Medicine Department at Orlando Health UF Health Cancer Center since 2013. Dr. Robinson attended the University of Central Florida, where she earned her master's and PhD degrees. Her professional psychology internship was at the VA Medical Center in Gainesville, Florida, with a focus in clinical neuropsychology. After a 2-year postdoctorate residency in neuropsychology, she returned to the VA as a staff psychologist. She is the current president of the board of Central Florida Brain Injury Support Group. Her research interests include the impact of stress, including the stress of pain and medical illness, on cognitive functioning, and the variables involved in healthy aging. Welcome, Dr. Robinson. Next to Dr. Robinson is Marcy Pegg. Marcy is a nurse navigator at Orlando Health UF Health Cancer Center. While she streamlines care and provides emotional support, Marcy is dedicated to educating patients with breast cancer and reviewing hematology treatment and counseling, their families about treatment, and diagnoses, treatment options, and also resources. She is a member of the Oncology Nursing Society and is currently pursuing her MSN in Nursing Leadership and Management at University of Central Florida. So welcome, Marcy. And last but certainly not least is Megan Euler. Megan is an occupational therapist and certified lymphedema therapist who practices at our South Seminole outpatient rehab as well as Lake Mary Cancer Center. She has been an occupational therapist for 7 years and a certified lymphedema therapist for 5 years. She loves working with oncology patients to help them regain a sense of normalcy during and post-treatment, as well as getting them back to doing activities they love and enjoy. Welcome, Megan. So what we want to do is go into some questions of our panel. So I'm going to turn things over to Dr. Ram. Dr. Ram, I have a couple questions for you. So let's talk about consultation. What can someone expect during initial consultation?
Most patients enter their diagnosis of breast cancer with seeing a surgeon because they have either an abnormal mammogram or a mass that needs to be biopsied. So the initial consultation with surgery will determine what type of biopsy needs to be done and obtain the diagnosis from the tissue. Sometimes the surgeon does the biopsy, and sometimes the patient's referred to radiology. But there's something that raises awareness that there's a problem, and that's why the surgeon sees the patient initially. The biopsy may be done in the surgeon's office, or sometimes we refer the patient to radiology for a special type of biopsy.
Thank you. How do you determine if someone needs a lymphectomy or a mastectomy?
Patients have a choice in their surgical treatment most of the time. Most small breast cancers can be treated equally successfully with lumpectomy and radiation therapy. Now, that surgical procedure will include sampling the sentinel lymph nodes, or the first lymph nodes draining the breast. So at that time, a lumpectomy and removal of some lymph nodes is done. Most early breast cancers can be treated that way. Many patients choose to have a mastectomy, and again, that's the patient's choice. The complete evaluation will include evaluating both breasts, evaluating often with an MRI to make sure there's no hidden areas that we don't see on the mammogram. And then a discussion of the options. And again, if a lumpectomy can be done, that's presented to the patient and they make the final decision.
Thank you. And what's the average time of diagnoses to surgery, the average timeline?
Once we have the complete pathology of the tumor, which includes the estrogen and progesterone receptor and HER2/neu status, we can make recommendations for treatment plan. Some cancers will need to see some patients with cancer will need to see medical oncology because they might benefit from chemotherapy before surgery. If a patient is recommended to have surgery first, often we can get them in for surgery. Certainly we'd like to within a month, which sounds like it might be a long time, but before we get all of the testing done, it may take that. But if everything's already done, it can be within a week or two. Patients choosing breast reconstruction, it will be a longer time because of the need to meet with plastic surgery and coordinate that. So that may be up to a month.
Great information. Now, if the cancer has traveled to the lymph nodes, how do you determine how many to take?
When we know a patient has cancer already spread to the lymph nodes, those patients are referred to medical oncology for a determination if they would benefit from chemotherapy prior to surgery. That way, when we do the surgery, we can still do the sentinel lymph node mapping and hopefully limit the number of lymph nodes removed. If lymph node metastasis is extensive, then a complete lymph node dissection is done. Patients have a variable number of lymph nodes, so complete dissection could include 10 to 30 lymph nodes. But we try to limit that by treating first. People with no lymph node metastasis determined clinically can have a sentinel node, and we remove somewhere between 1 and 5 lymph nodes initially, if they're negative.
Okay, negative. If we kind of focus on maybe some of the long-term side effects and complications of both a mastectomy or a lymphectomy, can you kind of go into that a little bit? What are some of those long-term effects?
With the lumpectomy, radiation therapy is part of that treatment considered breast conservation. And after surgery, there could be a reduction in volume of the breast. Radiation can also reduce the size of the breast and firm that area more, so there may be some asymmetry. And there can be some persistent discomfort with lumpectomy. Mastectomy, obviously the breast is removed, you have the cosmetic lack of that, and unless reconstruction is completed. So those are basically the long-term results.
Thank you so much, Dr. Rum. I appreciate your insight on all of our questions. I want to move to Dr. Constantino. So focusing on a medical oncology perspective, when will I first meet with my medical oncologist?
So generally when you meet with the medical oncologist, you've already received a diagnosis of breast cancer, and we know the receptor status. So if it's estrogen driven or HER2 positive or triple negative. So we generally have that information when the patients come to see me. Occasionally I see patients after they've seen the surgeon and had a biopsy, but before they've had surgery, and occasionally I see them after surgery. And that kind of depends on the surgeon's discretion, knowing whether or not they would need consideration of treatment before surgery.
What factors determine my need for chemotherapy, and how long does it last?
So we look at a lot of different things regarding whether or not a patient needs chemotherapy. It depends on the size of the tumor as well as the lymph node status and their ER/PR HER2, which is something that comes back on the biopsy. So generally, patients who are triple negative need chemotherapy prior to surgery, as well as patients who are HER2 amplified. If it's a very small tumor, we may go ahead with surgery and then assess that after surgery. Patients who are ER/PR positive, HER2 negative, generally go for surgery first. Sometimes we'll send a specialized test called an oncotype, and that will tell us if a patient who is ER/PR positive, HER2 negative, needs chemotherapy, would benefit from chemotherapy, and if they're high risk of recurrence. And so that test helps us a lot and has actually spared a lot of women from needing chemotherapy who previously may have, including node-positive women. Chemotherapy duration can be anywhere from 3 to 6 months of chemotherapy, and if a patient is HER2 amplified, we do 1 full year of targeted therapy for that HER2 molecule.
Thank you. How often will I have routine scans to assess my cancer?
So we don't do routine scans following treatment anymore. That used to be something that we would do on a regular interval, but they found that there was actually not benefit to that, and patients were having a lot of radiation exposure that wasn't needed, cost, and anxiety in that process. We continue to do mammograms on a regular basis, either 6 to 12 months after completion of therapy, and ongoing if you've had a lumpectomy. And then you would see your medical oncologist for routine follow-up regarding symptoms, blood work, and physical exam.
Now, you've alluded to follow-up, so that's actually guiding it to my next question. So how often will I follow up with the oncologist during my cancer journey?
I usually see my patients every 3 months for the first year, every 4 months for the second year, and then every 6 months, years 3, 4, and 5. And then at that point, patients can choose whether they'd like to see me annually or just follow with their primary care physician.
Okay, thank you. What are some long-term effects from medication that I will take?
So that's highly variable from patient to patient, but some of the things that stick with patients or are neuropathy. That tends to be one of the bigger things that we have with the chemotherapy that we give, and that is a numbness or tingling in the fingers and the toes, and it can be really annoying. We try to manage as patients are going through treatment and make adjustments so that they don't have that, because it can be permanent. Patients can also notice improvement up to 2 years as nerves are slow to regenerate. Patients lose their hair during chemotherapy, but it does grow back, and usually within 3 months of completing treatment, patients have hair covering their head.
It's good to know, thank you. Now, I've heard this terminology before, chemo brain. So what is chemo brain?
Chemo brain is something that patients experience during chemotherapy and sometimes 6 to 12 months after finishing chemotherapy. It's something where patients notice that they walk into the kitchen and they don't remember what they came in there for, or they need to make a list of things because they forget what they're supposed to be doing, or can't find their keys, or it's common things that everybody has, but it's amplified through chemotherapy.
Understandable. Thank you for that. So what is the purpose of long-term maintenance medication? And is there ever a time when I can stop taking my medications?
Yes. In patients who are estrogen, whose cancer is estrogen driven, they take hormone blocking pills for 5 to 10 years. Following completion of that, they are no longer on medication. The purpose is to starve the cancer of the hormones. So those are patients whose cancer is estrogen driven, and the hormone blocking pills block that estrogen, which decreases the risk of recurrence of cancer. We also use some maintenance medication in HER2-positive breast cancer patients.
Thank you. And last question. This comes up with a lot of, patients and the common signs, they're thinking that my cancer is coming back. So what are common signs that cancer is back?
So the prognosis with breast cancer overall is excellent. However, there are some patients that will recur. Breast cancer tends to like to go to the bones if it's going to come back, and that's something that we have patients monitor for signs of new pain, unexplained and persistent pain. Particularly, it tends to affect the trunk region, so ribs, back, hips, pelvis, less often knees, ankles, wrists, elbows. So those are common sites of arthritis, not breast cancer recurrence. But if patients have back pain that's unexplained, hip pain, rib pain, or I always tell my patients, if you're laying in bed at night and you're like, I think that's my cancer, call me because we should evaluate. If there's something, people have pain all the time. They have symptoms that come and go and they don't think anything of it. But when you've had cancer, your first thought is that's my cancer. And so if that's on your mind and it's bothering you, then I want to meet with you and talk about it and then perform designated imaging.
Wonderful. Thank you so much.
Thank you.
So I want to go to Dr. Swanek, and let's talk about radiation oncology. So when will I first meet with my radiation oncologist?
So ideally, it's best to meet with us at the very beginning, even before you've had surgery. A lot of times, like Dr. Rahm mentioned, patients have a choice in terms of whether they want a breast-conserving surgery like a lumpectomy or a mastectomy. And if you have fears or concerns about radiation and therefore that may influence your surgical decision, then it's really best for you to meet with us at the very beginning, and we're always happy to do that. A lot of times patients are in a hurry to get their surgery. They've got a lot of anxiety related to their diagnosis, and in that setting, it's of course perfectly fine to meet with us afterward, and at that point we can then move forward sort of pretty quickly with getting the radiation started if no chemotherapy is indicated as part of your treatment plan. But even if you may never need radiation, we'd love to meet with patients up front, and you can always request that from your surgeon or your medical oncologist.
Thank you. What factors determine my need for radiation?
Yeah, that's a great question. So one of those factors is the type of surgery that you have. So if you choose a breast-conserving surgery and you are, under 70 or don't have a very small tumor, there are a few exceptions where sometimes you can do just the lumpectomy without radiation, but the vast majority of patients will need radiation after a breast-conserving surgery. If you have positive lymph nodes, not always, but you often will need radiation after your surgery, even if you have a mastectomy. And so that's another reason to discuss with us as early as possible, so we can help you make decisions about your surgery based on the likelihood that you may need radiation afterward. But those are the factors, would be the type of surgery that you have and the lymph node involvement.
So a big question that comes up is, what is the radiation process like? Can you describe that for us?
It's definitely just something that people have no experience with, and if they do, it's often someone that they know who's had radiation to a different part of the body. And with radiation, everything or the side effects are very different depending on what part of the body we're treating. For breast cancer, if you go from surgery to radiation and you don't need chemotherapy as part of the treatment, then we typically try to get started somewhere between 4 and 8 weeks post-operatively. We don't ever start before 4 weeks because we want you to have a full month to heal, for your wounds to heal after the surgery. The first step is called a simulation, so you may hear that term if you are going through the radiation process. All that means is that we do a very straightforward non-contrast CT in our department that then I use to plan the treatment, and then the treatment starts about a week after that. Breast radiation ranges from 3 weeks to 6 weeks. Most patients, it usually ends up being about 4 weeks for patients without lymph nodes involved and 6 weeks for patients with lymph nodes involved. And that's daily treatment during the weekdays, so Monday through Friday. Only takes about 20 to 30 minutes each day, so it's frequent, but it's short visits.
Okay. Can I have radiation more than once?
That's a great question. We typically do not like to radiate the same part of the body more than once, but it can be done. But for example, if you had a breast cancer, recovered, and then years later had something else, another type of cancer that required radiation, if it's a separate part of the body, you can get that treated as if you'd never had radiation before. But with breast cancer, it does get a little bit tricky to re-irradiate, but it is something that we do occasionally on a case-by-case basis.
Thank you. As we know, you are trained in proton therapy. So my question is, what is the difference between normal radiation and proton radiation? Can you just explain that for us?
So that's, as you can imagine, that's a common question that we get at Orlando Health because we do have proton therapy available to us. The main things to remember are that the both types of treatment, so standard X-ray radiation and proton therapy, are equally effective in terms of breast cancer control, cure rates, things like that. There can be, not always, but there can be some differences in the side effect profile, and that's because generally proton therapy delivers less dose to nearby normal tissues like the heart and lungs. That said, most of the time we can get really nice plans with standard X-ray therapy, so there has to be a very strong argument to push for proton therapy for breast cancer patients. And occasionally patients have anatomy that just does not allow us to achieve a low enough heart dose or a low enough lung dose, and in that setting we explore proton therapy as an option. But the great thing about Orlando Health is that I feel like I can use whatever technology I need to use to give the patient the best care, and that patients can know that we're always thinking about all of the options that we have.
That is wonderful. Thank you for that. Are there any side effects of radiation? And if so, how long will they last?
Yeah, so that's a great question. So there are definitely side effects from radiation. The most common things that we see during radiation for breast cancer are skin reaction, and I'll explain that in a second, and then fatigue. And then there are a few more rare things that happen. The skin reaction starts at about the end of the second week of treatment and can linger for about 2 weeks after we're done. It's quite variable. So some patients have nothing more than a mild sunburn type reaction, and other patients can have blistering and peeling. And it really is difficult to predict, and it does have, there are some things that we can control to minimize that, but for the most part, we see patients every week to help stay ahead of it, but at the end of the day, everyone's a little bit different in terms of how they react to radiation. But the good news is that really no matter how severe the reaction, patients do recover very nicely within about 2 to 4 weeks after we're done with treatment. So similar to a sunburn, there can be some peeling, but then new skin comes in and patients heal up nicely. Like Dr. Ram mentioned, there can be some volume loss there almost always is to some extent some volume loss in the breast that we treat. It's often subtle, and if it's not subtle or if it bothers the patient, then we can have them see plastic surgery to discuss some options to make things more symmetric. And then there can be some long-term tanning that takes a lot longer to fade than the redness.
And my last question is, how often will I follow up with my radiation oncologist after my radiation is completed?
Yeah, so I see patients 1 month after they're done. If they have a bad skin reaction, I may see them 2 weeks after they're done just to keep an eye on it, but generally 1 month. And that visit, these days we've been doing those virtually often because patients are typically doing well, and if they have any concerns or want us to look at their skin, they have the option to come in, but they don't necessarily have to. And then from there, I see patients every 6 months for a year, and then at the 1 year post-radiation mark, I give them the option to go to annual visits. And then some radiation oncologists may then discharge them to the medical oncologist once we've seen them for about a year after they've finished treatment.
Great information. Thank you, Dr. Swanek.
You're welcome. Thank you.
Dr. Bates. So as we talk about plastic surgery, so what should I expect, when should I expect to meet with my plastic surgeon?
So that's a great question. Typically, we like to meet patients soon after they've met with the breast surgeon, so Dr. Ram in this example, so we can make a plan for them about what kind of reconstruction they would like, and we typically like to plan that first step of the reconstruction where we put in what's called a tissue expander, so it's similar to an empty balloon that we can fill in the operating room as well as in clinic, and we like to do that at the time of the mastectomy. The other thing that's nice is that we can then also plan. A lot of patients have questions about what type of reconstruction is right for them, and sometimes they haven't decided after they've met with their breast oncologist and medical oncologist whether they would like a lumpectomy with radiation or mastectomy, and so they rely on us to explain to them the differences in a reconstructive outcome that they can expect.
Okay. So So I think you've already kind of answered my second question, which are what are my options for breast reconstruction? So if you want to dive a little bit more
That's
into
okay.
it.
No, so there's a little more to talk about that. So typically, the two main options are going to be using your own tissue, which we call autologous reconstruction, and then the second option is going to be implant-based reconstruction. For most patients, no matter which eventual option you end up choosing, for most patients, the first step is to still put in that tissue expander that I talked about earlier at the time of mastectomy. What that allows us to do is to save as much skin of their breast skin as possible at the time of mastectomy, and get used to the natural shape that we want to give at the time of the final reconstruction, which will be the implant or using their own tissue.
How will I know which one is right for me?
That's a great question. So every patient, we evaluate every patient individually. Typically, if you've had other abdominal procedures, C-sections don't exclude patients, but for example, an abdominoplasty would exclude you from using your own tissue, at least from the abdominal region. And that's the most common site we would use to harvest and use your own tissue for reconstruction. There are other options, including the thigh, but those are typically smaller. We can make a smaller breast reconstruction. So depending on the patient's desire for her final bra size, that would be a point of discussion. Some women want something fast and easy, and that's typically going to be the way of going and using implants. That's a shorter surgery and a much shorter recovery. Of course, other things like whether they're going to have radiation will affect their final decision, because implant-based reconstruction in the setting of radiation therapy has a higher failure rate. So we discuss that with all our patients at the time of the consultation.
Thank you. Great information. You had brought up expanders earlier. So once I have expanders in place, can I change my mind to remove them and do not have any reconstruction?
Yes, so that's certainly an option, and that's a question that comes up with many patients who are unsure whether they even want any reconstruction at all, and that's always a choice. What I typically tell my patients, if they're unsure whether they want reconstruction, is that we get a better aesthetic result, final aesthetic result, if we do place those expanders at the time of the mastectomy, and like I said earlier, save as much of that skin as possible. If patients then afterwards decide that they want to abandon the reconstruction and go flat, then we can always take the expanders out and then remove that skin. But if that's done beforehand and then they later decide that they want reconstruction, then again, that skin is not there anymore for us to use.
Understandable. Thank you. Are only mastectomy patients eligible to have breast reconstruction surgery?
No, so certain patients with small tumors and a larger breast and a large breast and a small tumor in a favorable location of the breast would be eligible for what we call an oncoplastic reduction. So in that case, like all breast cancer patients, we work with the breast surgeon. The breast surgeon would perform something similar to a lumpectomy, where they take out the breast cancer along with some normal tissue around that. And then we would come in and design a breast reduction surgery and then perform a reduction on the other side if needed. And those patients will also go on to have radiation therapy because they had a lumpectomy and not a mastectomy.
How long will it take to complete my reconstruction?
Great question. So I always tell my patients the reconstruction is kind of a marathon and not a sprint. The process to fill those expanders takes about 3 to 6 months, and then you would have your final autologous or implant-based reconstruction. But then there's always a lot of touch-ups. Patients come in, especially for implant-based reconstruction, you can have rippling or wrinkling of the implant that's visible under the skin, and a lot of times we can fix that by doing some fat grafting procedures where we borrow fat from one part of the body and move it over the implant. If patients had required to have their nipples removed at the time of mastectomy, then nipple reconstruction is also another part of the reconstructive process that we have to talk about. So typically, I would say most patients undergo reconstruction over a approximately 2 to 3 year period. And like I said, there's usually lots of smaller surgeries involved with that.
And my last question is on long-term effects. Are there any long-term effects that can affect my daily living?
I think in terms of long-term effects, I would say they're pretty minimal. Of course, there's going to be scarring anytime you have surgery. That usually softens with time. There's nothing long-term, whether you have reconstruction using your own tissue or an implant, that would prevent you from doing all your normal day-to-day activities once you've healed. And that's typically 6 weeks after your final surgery.
Great information, Dr. Betas. Thank you so much.
Thank you for having me.
So I want to move to Dr. Robinson over to my left. So Dr. Robinson, a couple of questions for you. When we talk about psychology, what is the role of the therapist for breast cancer patients?
So a psychotherapist is a licensed mental health counselor who's going to really help you through the journey. There's lots of things that start to become very overwhelming during this process. If you look at this amazing panel who's here, you've got the wonderful Dr. Ram, a surgeon, you've got Dr. Consultation with medical oncologist, sonic, radiation, and then you Betas with the reconstruction, and reconstruction can go on for a year. It really becomes overwhelming. And there's so much anxiety each step of the way on how you're going to react, because you'll have these wonderful physicians who will say to you, we're not quite sure how you're going to react individually to this, but these are the potential side effects. And that can really start to be very worrying. And eventually that anxiety might get in the way of really having the best outcomes. So it's very
true.
important.
Yes, thank you. And thinking of my mental state, what are some ways in which breast cancer diagnosis can affect me mentally?
So there's some natural reactions that are normal and anticipated. So, for example, anxiety. It is worrying when you get delivered this diagnosis. There's no doubt about it. So that's normal and healthy, and sometimes we'll get sad at all of the changes that are taking place in our lives because of this diagnosis. And you can watch it impact your whole family. So I always say cancer is a family disease because it's going to impact everyone who loves you and surrounds you. And so it becomes really part of this slow progress where there's these normal reactions that are anticipated, but if you don't take care and understand that you need to have some tools to cope with them, it can start developing into something much more serious where it would be a mental health condition. So it could become a major depressive episode. It might become a general anxiety disorder. So we really need to get in there and give people tools to cope with the stress, and that's what my whole specialty is involved in. So.
Thank you. How do I know if what I'm feeling is normal, and when do I know that I need to speak to someone professionally?
Well, part of it is there's a lot of myths that are about cancer. So one of the myths that's out there and still quite common is that you've got to put on, this good attitude. You have to be, you got to put on a good face. So this sometimes gets in the way of people really expressing how they feel. And a lot of times they'll end up coming to see us, and they're actually depressed, and they're clinically depressed. But they won't have shared anything with their physicians. Because of this myth, they become very frightened that they have to be a good patient or they have to keep this brave face up, and so they haven't sought that treatment early enough. So really it's about understanding it's okay to say I'm not doing okay.
I love that. Thank you. What are the pros and cons of in-person support groups versus online, like Facebook or some social media?
Well, it's certainly been an interesting time for us, hasn't it? So treating oncology and patients during COVID has had some challenges for every single person on this panel, and I'm sure every single person watching us here from home. And with my whole team, it's been interesting because we had to suddenly switch on a dime, especially during quarantine, to see patients who we were generally used to seeing one-on-one at home via telephone or teletherapy. And being the psychologist that I am, I was very anxious. Is this really going to work? But what we found, it was actually quite liberating. A lot of times, there's so many appointments. Look how many people are at this table. That having to come back to the hospital to see a mental health therapist is also a little bit overwhelming. So the fact that they could stay at home and call in was really wonderful, especially some of our patients live 2 hours away from the hospital. So it really became very, very convenient. We found that it goes back to that it depends. It depends on personal preferences. There is not one size that fits all. Some people really enjoy just having that luxury to sit at home. They're feeling really tired. Fatigue is one of the most common side effects of all of the treatments that we've been talking about today. So not having to come in and drive has been wonderful, and picking up that phone really works for them. But there's others who really enjoy that social contact, sitting there and watching the expression of the face and feeling like there's only certain things they want to disclose to someone one-on-one in a room. So fortunately right now, we can offer both. If over the phone or on teletherapy or coming in works best for you, we can figure that one out now. So that has definitely been a big shift for us. And that's the same with our support groups. So for example, our breast cancer support group, right now, it used to be, prior to COVID, only in person downtown. But right now, we're offering it in person and over Zoom. So it's a really great experience. The folks that still want to come in and have that social can come in. But we also have the ability to see a lot more people as well via Zoom. So
I love there's a lot of options available to support our community and our patients.
What are some additional strategies to help patients get through the various aspects of their treatment? And also, how do I talk to my family about my diagnosis? I know you had kind of shared that.
yeah, again, it goes back to there's no one breast cancer patient who's the same. They're all individual, unique, different circumstances, different family circumstances. So part of it is understanding, and I have learned this over the years as a psychologist. Sometimes I'll walk into a room and say, "Hi, I'm Diane, I'm your psychologist," and they're like, "I don't want to talk to you," because it becomes very scary. So we have to kind of figure it out. Some people are really open to sitting down with a psychotherapist and really talking through the problems and those emotions that they haven't wanted to talk with anyone else. But for other people, that's just not going to work. So the Department of Integrative Medicine, what we're specialized in is trying to find evidence-based ways to help people cope with stress. So again, person who doesn't want to see a mental health therapist may well want to do yoga. And we know that's evidence-based for cancer patients, but then we have to adapt it to cancer patients. So we have a specialized gentle yoga. All our yoga folks are trained in that. And that really gives a tool to help people control their thoughts and their bodies. And we know if you can keep your body moving during breast cancer, you can have a better outcome because your body doesn't become deconditioned, but it's also this idea of how much is too much and not becoming too fatigued. So it's quite complicated, but having different professions there can really help. And so we have a multidisciplinary team who will figure out what's going to help you cope with stress.
Thank you.
So my next question is, do I still have access to resources once I've reached survivorship?
Mm-hmm. Yeah, there's a multitude of resources that are available, and we always say, the fear of recurrence is one of the strongest emotions a lot of folks have, and it can keep going year after year. So that emotional aspect doesn't really go away. The tools and resources we have, and you mentioned about talking to your family, we have a lot of those online, and they're there anyway. So we're part of a national organization called the Cancer Support Community, and right there online there's an amazing book called What Do I Tell the Kids? And it sort of steps you through because, again, no child is the same, and there's different ages and stages. So, for example, what you're going to share with your teenager is very different than what you would share with your 5-year-old. But it is really important for children to understand that they didn't cause the cancer. And this is one thing that really parents don't think about. They think if I don't talk about it, that my kids are going to be okay. But you kids know something's wrong. And a lot of times with their age and their mental development, they're going to think they had some part of that. And I think it's really important to know that there's materials online, whether it's during treatment or post-treatment, that are available to help you. And we have a wonderful resource that you can call anytime, no matter how far out you are in your journey, and help point you in the right direction.
Wonderful information. And one last question for you. What are some strategies to help us get back to feeling like ourselves again?
You know, I was just talking to Dr. Constantino before earlier about this whole idea of new normal. Boy, it's really been a hot topic, hasn't it? You know, we've talked for years with breast cancer patients about what is your new normal going to look like. This has been incredibly life-changing, and now we're in the middle of another life change with this pandemic. So getting back to some kind of rhythm is really about picking up the pieces of your life that you want. One thing that I find particularly fascinating about the patients that come to see me is that some of them, we have this new phenomenon called post-traumatic growth. We've all heard of post-traumatic stress, and we do find this in some of our patients where it's so overwhelming and life-threatening what you're going to, you develop this symptom, but some folks afterwards have this amazing period of growth where you reanalyze what your life is and what your priorities are, and it's quite extraordinary when a patient can look you in the eyes and say, honestly, this was the best thing that ever happened to me because I knew what I wanted from my life with more clarity than I've ever had before. So my goal is to help people get there, to that point.
Thank you so much, Dr. Robinson. Very great information. So let's talk to Marcy, our nurse navigator. A couple of questions for you. So what is the role of the nurse navigator?
So as a nurse navigator, my job is to ensure that your treatment plan goes off without a hitch. I like to tell patients I'm their concierge of the treatment, the one-stop shop. In constant contact with the medical oncologist team, radiation oncology, surgical oncology. My job is to make sure that all your scans, your exams, your treatment gets scheduled in a timely manner according to the physician's plans. I constantly review your medical charts to make sure that nothing is getting missed. I like it to say I'm the safety net. I also advocate for my patients. If they have concerns or questions, they can come to me, and I'm always there to help with education or reassurance for them while they're getting treatment.
I love that you use the terminology safety net. I love that. How long will I have access to you as my nurse navigator?
Once you receive a diagnosis, you have access to the Navigator, and I'm here throughout your entire treatment plan. The degree of which I am included varies, but even once you're in survivorship, it's more dictated by the patient how often they have access to me, but I'm always there for them. So throughout their whole treatment plan into survivorship, as long as they're a patient of the Orlando Healthy of Health Cancer Center, you know, they have access to their Navigator.
Oh, I love that. Thank you. And last question, you talked about some things that you help with navigating our patients. So what additional things are you able to help our patients with?
I can basically help our patients with anything they need. If they need help scheduling scans, if they're having financial concerns, if they need medical paperwork filled out, if they need more education, if they need help speaking to their family members, anything they can think of. If I can't help them, I find the resources for them. But my job as a navigator is to make sure that during this treatment plan and this, you know, kind of chaos or upheaval in their lives, that I'm that constant for them during this.
Very important resource. Thank you so much. So Megan, I have a couple of questions for you when we talk about lymphedema. So what is lymphedema?
Lymphedema is something that can occur with breast cancer treatments, and essentially it's swelling that occurs in the same area that you've had your treatment in. So we can see it in the arm on the same side as the breast cancer, in the breast if you've had a lumpectomy, and sometimes even in the trunk area as well.
What are my chances of getting a lymphedema?
It varies depending on what your treatment was. Usually depending on the number of lymph nodes that have been removed, that factors in. The more removed, the higher the risk for lymphedema. Also, with adding in extra factors of additional surgeries and then radiation therapy, that also can increase the risk and likelihood that lymphedema can occur. On average, studies kind of suggest that 1 in every 4 to 5 breast cancer patients will develop lymphedema at some point after their treatment. Unfortunately, it can occur in the beginning stages or it can occur years later. So it's something that we need to stay vigilant on so that we can be aware of something starting.
I know a lot of patients have this question. Is it life-threatening?
It is not usually. The only time that we would consider lymphedema to be more of a life-threatening would be if you let it go untreated, and infections were persistent and things like that, and then that could become more of a severe medical complication.
What are some of the signs that I have a lymphedema?
Some of the biggest signs of lymphedema, before we can even see them, you'll be able to feel them. So it would be heaviness or tightness in the arm that's affected. Sometimes even in the breast, you'll see some different skin changes that just look a little funny, things like that.
Okay. So how do we treat a lymphedema?
That's when you come to see me and we get very familiar. And that can include manual lymphatic drainage, which is a special type of massage that we do to the extremity to try to mobilize the fluid to a different area that has intact lymph nodes that are working. Other times we incorporate exercise, proper skin hygiene, and then compression garments are also a big factor if needed. And this also depends on how severe the lymphedema is with the treatment itself.
Okay, I mean, you talked about compression. So do I need to wear compression forever?
That varies as well. Normally, if you have lymphedema symptoms, if you're in the earlier stages, there is a chance that we can get you out of wearing compression. Maybe not completely, but at least for limited activities that bring on symptoms and exacerbate those. Otherwise, if it's a more severe case of lymphedema, compression garments are something that you continue to wear usually throughout the rest of your life.
Okay. And my last question is, does lymphedema go away?
If it's in an earlier stage, it can reduce and be much more manageable. The risk for lymphedema is going to be with you from the time that they remove lymph nodes and you have your treatment. Again, we don't know what causes some patients to have it earlier on and some patients can be later. Usually it has to do with different traumas and things like that. So it's always a risk factor, always something to be vigilant about and watch for those signs and symptoms. But overall, it can be well managed if treated effectively.
Wonderful. Thank you so much, Megan. So what we want to do right now is take questions from our audience. So throughout the discussion today, you all have been submitting your questions to us. And so with that, we have a couple of questions that's going to be passed down. Now, remember, you can continually right now at the bottom of your screen, you can submit questions on the Q&A portion. So I have a few questions that were just brought to me. So, I'm not sure, this is actually towards Dr. Constantino. So what is the maintenance medication that is used in addition to the hormone blockers that Dr. Constantino was referencing? So you were referencing this earlier.
For HER2-positive breast cancer, there is a medication called Nerlynx that can be used after Herceptin and Perjeta that's given orally for 1 year. And so that's it's a relatively new medication that's used after the Herceptin and Perjeta for 1 year. It does have its share of side effects, and so a lot of patients opt not to do it, but it is a choice.
Okay, thank you. So this next question is regarding radiation. So Dr. Swanek, I think this is for you. Do you utilize the, let me get this right, Oncotype DX test to help make decisions about the benefits or potential risk of doing radiation or not?
That's a really great question. There are some analyses from some of the big breast cancer trials that demonstrate that Oncotype is also, it's most predictive of your distant recurrence risk, which is why it's an important factor for the chemotherapy decision, but there is evidence that it also can predict a risk of local recurrence. And so for some patients where we're on the fence of radiation or not, I will factor that in sort of the back of my mind into the recommendations. It's not as clear-cut, its role in influencing radiation therapy, but certainly high Oncotype scores make me more worried that a patient has a higher risk of local recurrence, and that may push us more in the direction of radiation, only in cases where radiation could be indicated anyway. It would not change the standard of care, but it can be another factor that we consider. That's a really advanced question. So.
Right.
Yeah.
Well, thank you very much. So
smart
my
listeners.
next question is in regards to scar tissue. So I think I'm going to be looking down probably this way here. Can any I'm sorry, let me make sure I read this correctly. Can any recommendation treatment for scar tissue build up and pain in addition to massage and physical therapy. I'm hoping I'm reading that correctly from our audience.
I might take that
So,
one.
you want to take that one?
Could
Okay,
you
Dr.
repeat the
Bass?
question again?
So, I apologize. I'm going to add a little bit
Okay.
here. So, it looks like the question was regarding recommending treatment for scar tissue. So, if there's some scar tissue buildup and pain, in addition to massage and physical therapy, any recommendations?
So I tell a lot of, that's a great question, and a little bit difficult to answer, but I tell a lot of my patients that scarring is very much genetic. So I think the best predictor of how patients scar in the future is how you've scarred in the past. So, take a look at any other scar you've had, whether from falling down and, needing stitches or some previous surgery that you've had. And certainly for patients who don't typically scar well, and want to try something, the one thing I would say that's been proven in numerous studies is using some kind of silicone material. So they sell a lot of silicone gels, silicone sheets, and that can help with scarring. Another technique that's more advanced for deeper scarring is something I mentioned earlier, which is fat transfer. So for someone who has kind of a contour deformity or a really tight scar, fat grafting or fat transfer can be a good option for those patients. So I hope I answered that question.
You did. Thank you so much. I appreciate that. So why do some forms of breast cancer return and some don't? So who wants to kind of jump on that one? And which are more common to return? Anyone want to grab that one? Got Dr. Constantino? Looks like you're going for that one.
I'll take that one. So the big answer is we don't know. There are some cancers that look like they really should not recur, and they do, and there are some that look really aggressive, and they don't. But generally, we're more concerned with positive lymph nodes, with triple-negative breast cancer, and some HER2 amplified breast cancers. So something that's a continued ongoing surveillance. Breast cancer is something that can come back 25, 30 years later. So we don't exactly know when they will come back.
Thank you for that information. So this question is actually for all my panelists. So I'm going to read the question and I'll kind of let each of you one by one give your answer. So how would you address a person with a strong family history or genetic mutation of breast cancer wanting to stay ahead of a future cancer diagnosis? Okay, so I'll start at my end down here. Dr. Ram?
If a patient has a known mutation that truly increases their risk of breast cancer, which would be the BRCA1 or 2, and a few others, they do have the option of prophylactic surgery, meaning removal of the ovaries and the breast tissue. So that would be up to the patient. Generally, we also offer the option of close surveillance and would begin MRIs at age 25 in those patients with that mutation, and screening mammograms. And it's recommended once they decide they want to have prophylactic surgery, it's recommended they do so after they have children, if they want to do that, and then have the ovaries out as well as the mastectomies. But close surveillance is also an option.
Thank you. Dr. Constantino?
We also have genetic testing at Orlando Health. So if you don't know if you have a mutation, but you have a strong family history, that's an option for you. And that's a referral that can be done virtually as well. There are also hormone blocking pills that you can take, like tamoxifen, as a preventative medication for 5 years to reduce your risk of developing cancer if there's a strong risk.
Good answer. Thank you. You, Dr. Swanek?
I don't have much more to add. I would just add that if you do get a genetic test that wasn't done in the context of a genetic counseling session, that you seek that, because we do occasionally see patients who are scheduled for mastectomies for a mutation that doesn't actually put them at risk, but there was some sort of misinformation along the way, and then I'm sure it's happened where patients have big surgeries that don't actually change their risk. So I know we don't have a genetic counselor here today, but recommend that you meet with a very qualified team to discuss your mutation if you have one and whether or not it actually confers an increased risk before proceeding with some of those big decisions.
Dr. Davis, would you like to add anything?
I also don't have much to add. I do think there is, for patients who don't have a known genetic mutation, but do have a strong family history, I think that was part of the question. I think, and someone else on the panel can correct me if I'm mistaken, the recommendation is still to start screening 10 years sooner than your first degree relative was diagnosed. So, for example, if your mom had breast cancer at age 40, the recommendation is to start screening at age 30.
That's good to know. I did not know that. Thank you.
I think that's all right.
So I'm going to go to this side. So Dr. Robinson, any additional?
Yeah.
And if you would like me to repeat the question, just let me know.
No, it's fine. I think I have two things to add. First, we know that there's some behavioral things that you can do to lower risk of cancer. So obesity is linked with many cancers, and so really taking care of your health.
That truly do lead to increased risk. And family history can exist, and there is a mutation, and it can exist, and there's not an identifiable mutation. So make sure that that is carefully evaluated before you make a surgical decision.
Thank you. Dr. Constantino.
I just like to encourage everyone to get their mammograms, to tell their moms, their sisters, their best friends, their daughters. Please get your mammograms because early detection is so important, and you can avoid a lot of us if you can, at least some of us, if you can get that done early and identify things that are very small or calcifications prior to large cancers. Also, if you have a large mass that you feel or a lymph node that you feel, please get checked out. It's not too late. We can help. We've come a long way with treatments, with chemotherapy, management of side effects. And as you can tell, you have a huge team here that's here to help you through things. And we also have a pharmacist and a nutritionist. We have other people that aren't here that are part of our team as well. So we're here to help you get through it and get your mammograms.
Wonderful. Dr. Swanek?
Yeah, I would just say talk to your physicians, talk to us about things you're afraid of, because often they're not necessarily, sometimes they're true, sometimes they're not. I have a lot of patients who come see me and they're worried about hair loss, and the only thing they lose from radiation is their armpit hair, and most people aren't too concerned about that. So please express your fears to us so we can sort of talk you through those and help correct any sort of preconceived notions that may or may not be relevant to your treatment. But we're happy to, there's no stupid questions, and we're happy to answer even what may seem very obvious. So please talk to us.
I love that. There are no stupid questions. I appreciate that, because sometimes I have some stupid questions. Dr. Beatus.
Yeah, I would echo what everyone's been saying. I think, this whole panel and all of our partners here at Orlando Health, we're all excited to be helping you, and we're all, we look forward not to seeing you, of course, but if you have to, we're all dedicated to patient care. And I do think from the plastic surgery perspective, it is very helpful to have that consultation early on so that you can know your options in terms of reconstruction, and we can have that discussion before you've even had your mastectomy.
Thank you. I turn to Dr. Robinson.
Sure. I think biggest message is that you're not alone. You have a whole team of people who can help you go through this journey, and what's really wonderful is linking up with other patients. So coming to a breast cancer support group, we have one every month, third Thursday, third Tuesday of the month, 11 o'clock, available in person or Zoom. You come along, check that out. We have special guests, and the wonderful thing is to connect with other people and really not to be frightened to ask for help. And I think that's it. Thanks so much for arranging this panel today. And
Thank you. Marcy?
I agree with the other panelists. I would say, in addition to mammograms, make sure you're doing self-exams at home, usually in the shower. And also, like Dr. Robinson said, you're not alone. There's lots of patients out there that are willing to talk to you. You have a whole team of us working with you as well. And it's never too late, like Dr. Constantino said, but please make sure that you're putting your health first as well. I know sometimes as women we tend to put our health last and we put everybody else first, but if you don't take care of yourself, you can't take care of others. So please, please reach out if you need anything.
Thank you. Megan?
Basically, echoing what everybody else said, advocate for yourself. Don't be afraid to speak up and ask questions. Same thing with the lymphedema standpoint. If after surgery, at any point in your treatment, you're feeling something funny, ask the doctors to refer for a consult for any of our lymphedema therapists that we have within Orlando Health. We're all happy to help, and we all talk to each other very easily. So it's nice to have that team communication. That's always effective with helping treat anything that may come up along the way.
Wonderful, thank you. And we want to thank you all for joining us today. And just as a quick reminder, on your screen, you should have information of how to pick up your complimentary pink ribbon mask, that you'll be picking those up. There's going to be a follow-up email also going to be sent to you labeled Orlando Health Breast Decisions 2020, so be on the lookout for that coming soon. So, and a big thank you to our distinguished panel today. Thank you all so much for your great insight, your expertise in sharing with our audience today. We hope that you all have found the information provided very helpful. And if you have additional questions, please let us know. We'll be happy to guide you to the appropriate resources. And we hope to see you all in person next year. Have a great day and weekend.